Welcome and thank you for joining the Lake Superior Quality Innovations Network Adult Immunization Update. Ms. Holly Sandhart will now begin.
Good morning, everybody. Thank you for attending our webinar today. My name is Holly Sandhart, and I am a Clinical Application Coordinator for the Lake Superior Quality Innovation Network, and I am currently a coordinator on our initiative to improve adult immunizations in the state of Michigan. I wanted to take a moment to introduce our guest speaker for today's presentation, Ms. Barbara Wolicki. Ms. Wolicki is a registered nurse and holds a bachelor's degree in nursing from Eastern Michigan University. Prior to joining the Michigan Department of Health and Human Services, formerly known as the Michigan Department of Community Health, Ms. Wolicki had worked for the Garden City Hospital for over 23 years as a clinical partner with extensive experience in patient care across the lifespan. Additionally, her responsibilities included community and patient education and staff management. After joining MDHHS, Ms. Wolicki's role has included immunization nurse educator and immunization nurse consultant, a role which she currently holds. Ms. Wolicki is the author of many presentations, articles, and handouts focused on promoting national immunization recommendations, vaccine safety, and strategies to increase immunization rates. Ms. Wolicki is an annual speaker at the Michigan Department of Health and Human Services regional conferences and many state-based conferences, meetings, and provider office venues. Ms. Wolicki, you may begin.
Thank you, Holly. I do appreciate the opportunity to be able to meet with you, at least over the webinar, and be able to talk to you about adult immunizations. And with that, I'd like to just go ahead and get started. So just briefly, these are the goals that we are going to, I'm going to attempt to cover today for you. I'm going to look at the current CDC adult immunization recommendations based by age group and medical condition. And I will also give you information on screening for vaccine contraindications and precautions. Hopefully by the end, you'll walk away with at least 2 current resources on adult information, although as you'll see as we go through, I've embedded many more into this presentation. So let's start with the question: why are adults immunized? And we know they are because our rates in Michigan are prove that out time and time again. When we look specifically at national rates, we're looking at Tdap levels of only less than 16%, for instance, for adults. We know universally all adults need a Tdap. So why aren't more adults immunized? Well, the first thing we have to look at is the fact that adults are not aware of their immunization needs. Why? Because adults rely on you, the provider, to keep them up to date on immunizations. And if you fail to assess their immunization status at every encounter to ensure that they're up to date or know their needs for immunization, they will never become aware of those needs, and they will remain under immunized population. A couple of years ago, there was a lot of focus came to be on adult immunizations, and with good reason. Adults are just as special as children, and we need to be protected as well as our childhood and adolescent populations. And out of the concern in increasing immunization rates amongst adults, this paper was produced on immunizing adult patients, new standards of practice. There has always been adult standards of practice out there for adult immunizations, but they've been overshadowed by the initiatives for childhood to increase childhood rates. But with these standards of practice, we do have a new focus of where to look in determining the best way, the best strategies to increase immunization rates for adults. So let's take a look at the first one, assessing the status. It's key when you see any adult in your office that you assess their immunization record at every visit. So you need to look at where do you find all the information about that person's immunization history. There's basically 3 places you can look. You can review their immunization record in your EMR or chart, but don't stop there. It's always a good idea to ask the patient for their immunization record because they may have gotten 1 or 2 doses somewhere and actually had it jotted down in a card. Oftentimes, particularly our older population or our persons 65 and older do tend to keep that record card handy and oftentimes have it in their wallet. You just have to ask the question. But a key piece of information that most adult providers are overlooking is the value of the MICR record. The MICR stands for the Mission Care Improvement Registry. Our immunization registry now takes doses across the lifespan and deposits those doses into the registry. But how does that data get there? It takes the efforts of every practice who's vaccinating adults to ensure that when they administer that vaccine, that they immediately take that data and add it to the registry. By putting it into the registry, it's more valuable than your EMR or your chart copy, because the only ones who can see your immunization record that you hold in your practice is you within your practice. But the registry opens it up to all providers. Any providers who are signed on to access the registry have an opportunity to see what vaccines were given in your office, in a pharmacy, maybe in other points of impact for vaccinations across our state. So the key point here in ensuring that we're assessing the immunization records correctly is to make sure you have access to MICR. We'd like to see you not only using the MICR, but adding any doses you know about that person from their history into the registry. Just make sure they're valid doses before entering anything into the registry. From assessing the patient, the next step we go to is looking at the current recommended schedule. Every year, CDC produces new schedules for both children and adults. This is just one part of the adult schedule that we have available. On this side of the schedule, the recommended vaccines are laid out by the age of the patient. So, for instance, if you look down the middle of that chart in the 27 to 49-year-old category at the top, and you look down, you'll see 4 yellow bars marked under that age group. That means there's at least 4 vaccines that you should find record of in your patient's chart or in the registry. So it's important to know that every patient that comes in that age group has at least those 4 vaccines documented, or you have doses to give today. When you look further down on the record, you'll see a lot of purple or lavender bars. These indicate vaccines that are for risk groups. So, for instance, not every person age 28 would be recommended to get a hepatitis C vaccine, but there are a significant amount of people who would be. So that's the more complicated part of the adult schedule. We have to figure out what those medical conditions are, what are those risk groups that put people in more concerning areas for needing these vaccines that will prevent vaccine-preventable diseases. So we have a second side of the schedule, and that's laid out based on medical or other indications. Why other indications was added to the schedule is because if you look at the far right of your screen, the very last column shows you healthcare personnel. Being on this call today, I'm going to presume that you're all healthcare personnel. And when you look down that list, you'll see that if you're in the age group of 27 through 49, your 4 yellow bars have doubled. There are more vaccines needed simply because you're more vulnerable in where you work. And so we want to better protect you, and therefore more vaccines are needed. So look across the chart. You'll see there's recommendations for pregnancy, for men who have sex with men, kidney failure, heart disease, diabetes, and so on. A lot of risk groups here that can be identified within amongst your population, but you have to screen and know your patients before you can really determine what vaccines they need. You will see those red bars on there, and those are kind of concerning to some people. But they really deal with live vaccines, which we'll discuss in just a moment, and they deal with people who might not be able to mount good immune responses. So there are times when we cannot vaccinate certain people, and that's what these red bars indicate. So what types of vaccines do we have? We take all the vaccines that are on the schedule, and we divide them into 2 groups. The first group we will call the live attenuated vaccines. A live weakened, and in this case, they're all viruses, so a live weakened virus that when I inject it into your body or I put it into your body intranasally, such as the intranasal flu vaccine, your body is going to produces immunity against this weakened disease-producing virus that has just entered into your body. When it's administered, it replicates and produces immunity, but without causing illness, and that's the key point here. It's such a weakened virus that your body is able to make an immune response from time, and you will not get the disease. The key here is, though, some people don't have the best immune system. So when we look at persons who we consider to be immune suppressed, for instance, patients who are cancer patients, maybe taking chemotherapy or radiation, certain medications, such as steroids, cause immunosuppression, we have to be cautious in giving live vaccines to that group. So there are a few people that we cannot vaccinate with these live vaccines, such as varicella and MMR, measles, mumps, and rubella. The other group that's contraindicated to receive live vaccines is someone while they're pregnant. So when a woman is pregnant, while we aren't really concerned about the risk to her, we are concerned about the theoretical risk of transferring this live virus to her fetus. So just to be sure it's safe, we're waiting outside of pregnancy. 1 month before a person becomes pregnant, we'd like to avoid giving live vaccines, and then certainly during the pregnancy. But the day that baby's born, she is no longer pregnant, and she's certainly eligible to get these live vaccines. Inactivated vaccines are just that. They're heater chemically treated to be killed. They cannot cause disease, even in immune-compromised persons. So one statement I want you to hear very clearly and repeat it to yourself is that the flu vaccine cannot cause flu. In other words, you go to get your flu shot, you might not feel so great afterwards. Maybe you'll get a headache, maybe feel a little bit achy, maybe you'll even run a low grade temp. That's your body doing what it's supposed to, make an immune response against that virus that was put into your body. The bottom line is it can't give you the disease. These, because they are inactivated, generally take more doses to fully immunize you. And so, therefore, sometimes you have to come back, such as the hepatitis B series or the HPV series. All the vaccines that are inactivated are the majority we have, and you'll see listed at the bottom of the slide. Let's start with our focus of this month. We always have one vaccine that's in the top running every month, and certainly this is the start of flu season. We already have seen a couple cases of influenza within our state that urgent cares have reported, so we have an inkling that flu is heading our way. Key point is that everyone who comes into your practice who's 6 months or older should receive a flu vaccine. There are very few people that have a contraindication to receiving a flu vaccine, and we'll discuss those a little further as we go on. So in order to protect those persons that are most vulnerable to flu, are the people who will have the most complications to influenza, we need to vaccinate everyone around them. That includes the healthy people. But don't think you're vaccinating everybody just to protect vulnerable people. Healthy people as well can succumb to influenza disease, so we do need to make sure they're protected. This next slide looks really busy, and the reason I put it up is because it is a busy slide. You're going to see a lot of acronyms associated with flu, and they're listed at the top and spelled out with what they are, and we'll again discuss these again a little further in a minute. And what I want you to realize is that there are a number of flu preparations that you might have chosen to buy, and each one of them may vary by the age that's taken to give into a person. So this while isn't a problem in an adult practice, because as you can see, all of these can be given to most of these can be given to 18 years and older, it is an issue in a family practice. Make sure that you've got a vaccine that can cover your whole population, and that you haven't chosen a vaccine that maybe limits you only adults when you're seeing children. There is one vaccine on here I'll bring your attention to, and that's the Fluzone High Dose. You'll note that that's only for 65 and older, so certainly if you have that in your fridge, you want to mark that box very clearly so that there's no mistakes. Let's look a little bit further into influenza. We have 3 basic types of influenza vaccine out there. There's the inactivated influenza trivalent. That means trivalent is 3. It means it contains the protection against 3 flu strains, 2 A viruses and 1 B virus. If you go to the next category, it's quadrivalent. It's basically the same thing. It's a flu shot, but here instead of protecting against only 3 strains, it protects against 4. There's an additional 1 strain of B protection in a quadrivalent vaccine. Check your fridge. Know which one you're protecting your patients against, because they may have that question for you. When you look at the ages, there is a brand out there, Fluzone, that can be given to 6 months and older. So we say that the flu shots can be given to anyone 6 months and older. But again, check your brand to be sure what age group you have. If you look at the 2 categories there, who these are recommended for, they are the same. They're recommended to get the flu shot, whether it's trivalent or quadrivalent, to anyone who is healthy, to anyone with any underlying medical condition. This includes your immunosuppressed persons. And if you're pregnant, this is the vaccine that you can have. If you look to the 3rd column, live attenuated influenza vaccine, LAIV, it is a quadrivalent vaccine, so the same 4 strains are in there that were in your quadrivalent flu shot, but the age is more limited. This vaccine can only be given to persons 2 through 49. and there's caution in giving this vaccine, more precautions that are involved. You really need to give it to people who are healthy and who are not pregnant. If a person has an underlying medical condition, for instance, if they have asthma, you might be able to give them this vaccine, but there's precautions to that. So you have to decide, is the benefit worth the risk that maybe if I give this intranasal vaccine to a person, that they might have some wheezing later on. So you have to really look at benefit versus risk. And generally, we end up looking at the risk as being a bit more magnified, and we go ahead and get the flu shot instead. The third vaccine that I just want to focus on today would be that high dose that I mentioned earlier. This is really a key vaccine to consider for persons 65 years of age and older. If you look at the slide, it states that it's 4 times more antigen in this vaccine than in the standard flu vaccine. So it's 4 times more potent, 4 times more concentrated with antigen. You wouldn't want to give this to somebody under 65 because their immune system's working okay, and they should mount a good response from the standard flu vaccine. But as you know, as you get older, your immune system tends to wane a bit, and it's harder to get an immune response from any vaccine. So therefore, this is a strategy to see if we can boost the immunity. The downside in using the flu high zone, if you'll notice, is it's only a trivalent vaccine, so it's not got that fourth component, that second B virus strain. Because of that, CDC states no preference between the standard dose and the high dose. It's really your decision which you use. Just make sure you're using the right vaccine for the right person. Just so briefly, there are other, in fairness to the rest of the manufacturers out there are other vaccines available that account for the rest of the flu vaccine we see out there. There's an IAV4-ID. That stands for intradermal. This vaccine comes in its own special syringe. Don't make up your own. It's a very special syringe that has a very tiny needle on it. You want to get this vaccine just under the skin layer, and that's what this is intended for. The good news with this one is it has less antigen per strain, so you're giving somebody less vaccine or less amount of vaccine than you are when you give them the standard flu dose. So many people, for that reason, like this vaccine. Limited age, though, 18 to 64. Cell culture vaccine is made in a different way. It's made away from egg, but it still contains, because of the process of making the vaccine, it can be considered completely egg-free. So even a little bit or a trace of eggs could cause a problem in people highly allergic to eggs, so be cautious of that. When you look at the last one here, the recombinant IIV3, it is the only true egg-free flu vaccine that we have. So this is an option for people who are allergic to eggs. But having said that, it's estimated that well over 90%, if not even close to 99% of us who say we have an egg allergy really can take a flu vaccine. So keep that in mind. This algorithm that you can find at the website at the bottom will provide you with information that allows you to walk through, step through the person who says they have an egg allergy and be sure that they can't take a flu vaccine before you tell them no. Because the majority of people, again, who say they have an allergy will be able to take a flu vaccine. So let's now turn to the next step in the immunization standards of practice, and that's to share your strong recommendations. Well, strong recommendations can look a bit different to everybody, but the bottom line is when a provider's staff stands up and says to a patient, I know that this is a good thing. I recommend that you take a flu vaccine, you take a zoster vaccine or a pneumococcal vaccine. The rates go up in that practice. What you say to a patient will make the difference between them getting vaccinated or not being vaccinated. Strong recommendations do count. So be sure that adding into that recommendation can be comments like, I always take a flu shot. I would vaccinate my family. I make sure my mom is vaccinated, my grandparents are vaccinated, whatever avenue you're coming at. But this is where we're going to increase our rates, what you say to a patient. You want to also ensure that all staff are up to date on their immunization recommendations. It only takes one person going around saying, I'm giving you this flu shot, but I would never take it for myself, to really throw off rates and to see less people in your practice hesitant to take the vaccine and oftentimes leaving the office without being fully protected. When you do have concerns about vaccines, you need to seek out information that's scientifically based. We have a lot of myths out there, we have a lot of rumors, we have a lot of access to the internet, and oftentimes that information is not accurate. So the only thing I really ask you to do is make sure whatever you're telling a patient or whatever you're thinking is true about vaccines yourself has scientific base to it. If you ever need help with that, our local health departments all have immunization groups, and they are more than happy to help you through finding the information you need to make sure you're using that scientifically based information. I mentioned earlier that healthy people also need a flu vaccine for themselves. These are just two stories we have in Michigan that are very sad. The first one is Nico Yatis. What he's talking about is the impact of losing his sister when she was age 5 to influenza. A healthy little girl that was healthy one day and gone the next. This impacted his family, and even though he's in college now, he wanted to share his story and tell us what this meant to his family in losing his sister to influenza and implore people to go ahead and be vaccinated. The next story is about the McCormick family. They want to share Ashley's story, a perfectly healthy 23-year-old nanny who succumbed to influenza and passed away. You can read her story online and in these posters that we have available. You can find those if you can't read it here on the Michigan.gov/immunized website, and certainly we provided those in our AIM toolkit. All of those resources are listed on the final slide. Let's turn to pneumococcal. Pneumococcal vaccine is getting to be a bit tricky. And for those of you who are using both brands, and indeed if you're vaccinating people 65 and older, this is a key vaccine that you have to focus on. There are two brands of pneumococcal vaccine out there. One is pneumococcal polysaccharide, or by the brand name Pneumovax, and the other is pneumococcal conjugate, or the brand name Cardinal 13. There are some clear rules to these vaccines. So when you have these two vaccines, and in a minute I'll discuss who needs these vaccines, but some of the people I'll discuss will need two vaccines, both of these vaccines. And so here's some things to remember. If someone needs both of these vaccines, do not give these two vaccines on the same visit. You will not get the optimal protection if these vaccines are given at the same time. They interfere a bit with each other. So keep that point in mind. The other is that the pneumococcal conjugate works best if it's given first. So if someone needs both, always give the pneumococcal conjugate first, then followed by the pneumococcal polysaccharide. And in a moment, we'll talk about the intervals between giving these two vaccines. Let's look first at Pneumovax because it's likely the one you're more familiar with adults. It's the one that adults often call the pneumonia shot. It really protects against invasive pneumococcal disease. So we have to look at who's at most risk for this disease. Who do we want to vaccinate? We want to make sure that we administer one dose to persons 19 to 64 who either smoke cigarettes or have asthma. 50% of the people in a study, 50% of the people who had invasive pneumococcal disease also smoke cigarettes. So that's why it's considered a risk group. We want to administer one dose to persons aged 2 through 64 with any of the risk groups listed here: chronic pulmonary, kidney, heart disease, diabetes, alcoholism, CFS leaks, and cochlear implants. It's important to make sure these people receive one dose. But they only need one dose between the ages of 2 through 64. So look at their record. Make sure they haven't already received one dose before you give them another. That's where the registry becomes important, so you can find out what other people have done with this person and what vaccines they've received in other places. For people at highest risk for pneumococcal, we want to give them 2 doses between the ages of 2 through 64. This includes people who are immune suppressed caused by disease or medications, certainly our HIV and our persons with cancer, and people that have a spleen that either doesn't work properly or they have had their spleen removed. These people are the people at highest risk for disease, so make sure we give them 2 doses of vaccine between the ages of 2 through 64. If for the people who do need 2 doses, make sure those doses are separated by 5 years. Then routinely, once a person becomes 65 years and older, we want to give them one final lifetime dose of Pneumovax, one last dose. Regardless of their risk factor, it's just one more dose once they turn 65. But it's all persons that need it. So wipe away what you gave before. Don't worry about what they had before 65, and make sure all persons 65 and older from that birth date on have one dose recorded in your record. The next pneumococcal vaccine is newer to the market for adults, and indeed it is, if you look at the licensure, only recommended up through age 9. But because this is indicated and can actually decrease about 45% of the pneumonia we see, it is an indication and will work well in adults. So this vaccine was added to the schedule. But the key here is that people at high risk, or even people at 65 and older, only need one dose of this vaccine sometime in their lifetime. So if you have a person who's age 6 through 64, who has one of the risk groups listed on the slide here, and they've never had a dose of PCV13, then you want to make sure you give them a dose during that age period. If they manage to make it to 65 years and older, and they've never had a dose of this vaccine, then you want to give those people a dose at that time. This vaccine has only been on the market for less than 5 years. So you really only look back in the charting to see if they've had a PCV vaccine within about the last 5 years. Vaccine given before that point was a different type. It was PCV7 that had less protective antigens in it than this one does. So protected against less serotypes. So just look back through about 5 years, see if they've had a dose of this, and if they haven't, in risk groups or 65, make sure you give them a dose. So I want you to look on this chart. Well, I've provided you with the separation between the two doses across the lifespan. I really want you to focus in on the red box where it says 19 years of age and older. If you have those persons that are high risk and needed a dose of this vaccine, this is the people that needed this dose of vaccine in that 6 through 64 group, you always want to give the PCV13 first if possible, because then you only have to wait 8 weeks before you give them the polysaccharide vaccine or the pneumovax. If you inadvertently have the patient get the pneumovax first or the PPSV23, you have to wait a full 12 months before you give the conjugate. Looking at a person who doesn't have a spleen, you don't really want to have to wait a long time to fully protect them, so it's important to know which vaccine to give first. When you're looking at a person 65 and older and they're immunocompetent, meaning they're not in any of those risk groups listed under 19 years of age and older, you're not in as much of a hurry. It's not as needful to get the doses in so quickly or so close together. So for the majority of people who are 65 and older who need both vaccines, you're going to give them the PCV13 first for the Prevnar 13, wait 12 months, and at their next annual visit, give them their PPSV23 or their pneumococcal polysaccharide, and vice versa. They get the polysaccharide first, it's a 12-month wait before the conjugate vaccine. So you can say it's a little bit easier for 65 and older, but always remember, an older adult who may be getting their spleen out, but the 70-year-old going for a splenectomy, we don't want to wait 12 months to fully vaccinate them. Default to the high-risk schedule and give them those doses appropriately and in a shorter time span. Pertussis has been a challenge in our state for a number of years. We have seen pertussis rates go up and down, but consistently they have never fallen to a rate that we are of less concern. Pertussis is an issue for anybody who has respiratory illnesses. So certainly in flu season, when people have more complications to flu, the most prominent complication to flu is pneumonia, which clearly taxes somebody's respiratory system. We don't need them assaulted by another disease out there that can be prevented, such as pertussis. So it's important to get everybody vaccinated for that reason. But the other reason is just because babies die from pertussis. Infants less than 12 months of age are the greatest risk for hospitalization and certainly from death. So we do want to look at us, the adolescents and adults within our community, as a vehicle to best protect vulnerable people and to protect, in particular, these babies. You'll see at the bottom of the slide, there's a story about a baby in Michigan who succumbed to pertussis. She was only 3 months old. When we look at pertussis disease, you'll see that we've had an increase in 2014 over 2013 by 43%. And clearly our numbers simply are not going down, and we need to look further at who we're vaccinating and assuring that everyone gets this vaccine. As I mentioned in the beginning, only about 16% of the adult population has had this vaccine, so you have more than enough opportunity to use a lot of Tdap up in your office. It's routinely given to adolescents at 11 to 12. But the bottom line is, if you haven't received a dose by the time you're 13, then you need a dose at the next visit. So look at all of your patient charts and ensure that everybody has either had a Tdap or you're planning on giving them one today. Because we're so concerned about pertussis, there were rules put in place to determining how far apart did you have to put this Tdap dose from, say, a TD that you might have bought for wound care or simply that for preventative care. The key point is that you need to have, in order to have the least local reaction, you want at least 5 years between the doses. But because pertussis is such a concern, we want to go ahead and give this dose of Tdap regardless of the interval since the last TD booster was given. Yes, that means that the risk there is that you might get a larger local reaction than you were expecting, but the benefit is going to be protecting a lot of vulnerable people, including young babies. I just want to touch briefly on other strategies we're using to protect these babies. If you look to the bottom of this slide, you'll see cocooning infants. That's not working as well as we thought either. Not enough adults are protecting that baby by getting their vaccine. So they moved to another strategy in 2012. It was a lot of research had to be done to ensure that it was okay or it was safe to give a Tdap dose during every pregnancy. And that's exactly what we're doing now. We're using the mom as a vehicle to increase the protection that she can pass on to her baby. So the optimal timing of that vaccine is in the latter part of the pregnancy, during the 3rd trimester. But this will best ensure that that baby receives some protection from mom. About 50% of the moms in 2014 did just that to help their babies, and we're working with the rest to ensure their babies are protected as well. We don't want to look at Tdap as just a pertussis vaccine, so don't lose sight of the fact that tetanus is important as well. If anyone comes into your office with a wound that is either not clean and minor, meaning it can be large and clean or very small but dirty, then there is a need to look at their tetanus history. When you're looking at that, I've shown you there's a piece that we have available. It's posted at the Michigan website, listed at the bottom, and I've highlighted in the red box the adult portion of this. You need to make sure persons have had a 3-dose primary series of tetanus before a booster dose really does any good. And the information is here. Just don't forget, there's more important. Pertussis is not the only important component of the Tdap vaccine. In discussing hepatitis B and hepatitis A, I just wanted to challenge you to look at the risk groups for hepatitis B. Oftentimes when I'm presenting to groups, I say to them, who should receive a hepatitis B vaccine? And often people come back with healthcare personnel. I think we have that ingrained in us. But the other thing that comes back a lot is injection drug users. And that's true. Those are 2 groups that we do want to protect. But there are many more groups that we need to protect. And even a more recent risk group for hepatitis B that you might not be aware of. Diabetes has now become a risk group for hepatitis B, and that we should ensure that all persons under the age of 60 have completed a 3-dose series of hepatitis B. If you got it as a young child, you don't need to repeat it, but you do need to make sure that they've had those doses and they are recorded. Why? Why is diabetes a risk group for hepatitis B? Simply because hepatitis B is a very virulent virus. It can actually live microscopically in microscopic blood on a hard surface for up to 2 weeks. Meaning you come along, somebody drops blood on your table, your exam table, whatever, you clean it up with an alcohol wipe or just wipe it off with a cloth. You don't go get that disinfectant that will kill the viruses in there, and that hepatitis B remains a live virus, even though you can't see it, for up to 2 weeks. So what was happening, people were using glucometer units or blood glucose monitoring units, if you will, and they weren't cleaning them well between patients. And indeed, they weren't even changing the slides or really looking at universal precautions when using these types of devices. And we know oftentimes in hospitals now, everyone has their own unit, and we don't think of this as a problem. But for many, many years, glucometers were shared, and in certain places, they're still shared amongst patients. And this came to light in long-term care facilities. So if you are working in those types of areas or you are sharing glucometers between patients, be very careful because this is causing hepatitis B to spread from one person to another. You can look at the rest of the risk groups there. Certainly, if anybody has an assault to their liver, we don't want to give them any more issues, so we're going to give them hepatitis B vaccine, and so on, and you can read through the rest of the list. But I do want to point out just one more before I move on, and that is more than one sexual partner in the last 6 months. That is actually one of the more growing groups of concern in people getting hepatitis B. People who have more than one sexual partner in the last 6 months tend to be more at risk for hepatitis B. Also keep that in mind. Healthy, active people can get hepatitis B. Who should receive hepatitis A? The recommendations include all adolescents, so all children under the age of 18 are being vaccinated with a 3-dose series. But when we get to 19, it becomes that vaccine only if you're at risk. So I've listed here some of the risk factors, such as chronic liver disease or people who are receiving clotting factors. If you already have hepatitis B or C, you don't want to get another assault to your liver, so you get hepatitis A protection. A lot of people don't realize how many of places you go that you're putting yourself at being vulnerable for hepatitis A. So go to the CDC website, cdc.gov/travel, and check to see what are recommended vaccines for the area that you may be traveling to. That means your patients as well. Good news is, probably once we get to be about 40, we don't need hepatitis A vaccine, because the bad news is we likely already had hepatitis A virus in our body. Hopefully we cleared it out and it won't become a chronic issue for us. But in some cases it does. So this is still as concerning as some of the other hepatitis that we look at. And having said that, as we start to see decreases of rates of hepatitis A disease within our communities, because more and more of our children are being vaccinated, we are going to see less and less of us as adults get hepatitis A. So while we have been saying 40 and older, you might want to get tested before vaccinating, that may well change as more people are protected and we see less disease. The schedule is at the bottom of your slides for hepatitis B, we just passed, and here. I want to make a point about the hepatitis A schedule. You see somebody and you give them a dose of hepatitis A. Be sure that 6 calendar months go by, regardless of what age they are, before you give the second dose of hepatitis A. If you give it in intervals less than that, the second dose won't count. And now you have to call that person back and repeat a vaccine. I'm going to turn just briefly to looking at, and I apologize, I just went over the slides. I apologize for that. Quick fingers. I want to take a look at HPV, human papillomavirus, and the vaccine that we have. We kind of have a problem out there. HPV virus does cause an awful lot of concerns in our community. About 79 men and women, both in their late teens and early 20s, are infected with HPV. So certainly there's a lot of opportunity to spread this from one person to another. About 14 million people become newly infected each year, and so the numbers can continue to grow. The concern is that approximately 12,000 women are diagnosed with cervical cancer, and about 4,000 women die annually in the United States. 91% of the cases of cervical cancer are caused by HPV. So you can imagine that if we have a vaccine on the market, which we do, that can decrease the likelihood of women getting cervical cancer by decreasing their likelihood of harboring that HPV viruses that cause it, we could have great impact in decreasing the number of cancer cases we see. I do not hesitate to say to a person, HPV vaccine is a vaccine to prevent cancer, because that's exactly what it is. Studies show it works well, and we need to get that message through. We need to vaccinate everyone, certainly at an early age. The word of text to you in the adult arena is that many of our 11 to 12-year-olds are not being vaccinated. Many of our 14 to 17-year-olds aren't either. So they're going to reach adulthood, 19 and older, and still maybe have not started or not being complete with HPV vaccine. So this is your opportunity as adult providers to ensure that less of your patients have a concern about cervical and other cancers caused by HPV. Remember, it's not just HPV caused for cervical cancer, it's vaginal, vulvar, and it's other cancers as well, such as anal cancer. There's instances where HPV causes oropharyngeal cancer, and it causes penile cancer as well. So So using these types of vaccines can be impactful. The ages are listed here. We have 2 vaccines on the market that I'm going to discuss. Cervarix is certainly on the market still. It's HPV-2. It only has 2 serogroup protection in it. I'm not going to discuss it any further because that vaccine is only given to females and less than 1% of our population are taking it. 99% of the vaccine that's in the market is Gardasil. And right now we're transitioning from Gardasil 4 to Gardasil 9. Why did they do that? Well, when you look at Gardasil 4, 6 and 11 are low-risk types that cause 90% of the anogenital warts we see. 16 and 18 are impactful against cervical cancer. 70% of cervical cancer we see is caused by 16 and 18. So the company has gone further. The Merck company has developed another vaccine, including those first 4 serotypes, and adding 5 more. We can increase protection overall in women against cancer by 15% by just these additional serotypes, looking at all the cancers that HPV affects. And in males, about a 4% increase in protecting them against cancers. So it's a big impact in using 9, and that's where we're moving to. Look at your ages here, look at the schedule. It's the same no matter which vaccine you use. So regardless of which vaccine you have in your fridge, make sure everyone ages 9 through 26 is fully protected with 3 doses of this vaccine. Many questions have arisen about this vaccine, and due to limited time, I just want to share with you a couple of resources. I know this is an adult talk, and when you look at these handouts, they really look to project to pre-adolescent adolescents. But if you get these handouts out, you are going to find tidbits, information that you might be able to use in promoting this vaccine within your practice for your young adults. So these handouts are not just for your parents and patients, they're also to help you be more familiar with this vaccine. So I encourage you to go to our website and take a look at those. Let's look briefly at live vaccines. Live vaccines are funny because not only do we have some precautions on them or contraindications to certain groups like immune-suppressed persons or women who are pregnant, they also have funny rules to them. Live vaccines only work the best together if you put them in on the same day or you separate them by 28 days. So that's what you need to do. The next line there, what to do if you don't do that, is how you fix the problem. Let's not start with the problem. Let's figure out how not to make the problem. Give all the live vaccines that are recommended or that person needs on the same day, and then you can be assured they'll work well. You may not be aware of it, although more people are, that there was a measles outbreak in Disneyland, but we have a huge resurgence of measles throughout the world, and this is impacting people in the United States. And indeed, in 2014, we saw 664 cases of measles in the United States versus only 37 cases in 2004. So we are seeing an increase in vaccine-preventable diseases simply because people are not getting vaccinated or being vaccinated in less numbers than we've seen in the past. In August of 2015, throughout the United States, there were 188 cases of measles. Much decrease from last year, but still very concerning. It's out there, folks, and we need to keep our rates up to ensure that people are going to be protected against these diseases. We're looking at all of your adults who come into your practice who are 58 years and younger. Those are the people that you're focusing on to ensure they have at least 1 dose of MMR in their record, or they have lab evidence of immunity, or lab confirmation of having had all 3 diseases, measles, mumps, and rubella. Make sure those people who don't, 58 and younger, receive 1 dose of MMR. Certain persons are high risk for MMR, and we want to go a little further to ensure that they're best protected. That includes travelers outside of the United States, healthcare personnel, and college students. When someone needs 2 doses, make sure you separate them by 4 weeks to ensure both doses are what's called valid and count towards protection. Varicella is out there still. We still have cases of chickenpox. And again, as we see people starting to decrease the thoughts about getting vaccinated against chickenpox, we're going to start to see more cases. We used to see about 4,000 cases in our state. Now we see far less than 400. So this vaccine has made a big impact on our public health and well-being. So we have to make sure that everybody who could be still vulnerable is protected. We're looking at anybody basically age 35 or younger, and we want to ensure in their chart that they've had 2 doses of varicella vaccine, that they've been diagnosed with varicella disease, diagnosed with herpes zoster, because you can't get zoster without having had shingles, or there's a verification of history of chickenpox disease. When I say that, Mom says as an adult you can't walk into a provider office. You should not accept, yep, my mom said I had chickenpox at age 5. That's not good enough. They need to be able to describe the case, tell you in detail what it looked like. Otherwise, you should certainly be considered doing a titer or making sure that that person has got doing a titer to ensure immunity or making sure that person gets their 2 doses of vaccine. Herpes zoster or shingles is something that affects our older population. You want to give 1 dose to everybody 60 and older. You want to make sure that anybody coming in your office that's at that age group, that they're protected. It's a high risk for zoster or shingles, and we want to make sure that everyone who we see at 60 and older has the opportunity not to get that disease. I want to just briefly talk about pneumococcal vaccines. We have 2 vaccines on the market, and you'll see here that there's very few groups that are actually susceptible to this disease. So look at this closely, and I'm only going to focus in on 2 of them. One is Pneumococcal conjugate vaccine for adolescents. Highest risk for disease is between ages 16 through 21. So we want to make sure any of our adolescents up through 21 who did not receive a dose at least 1 dose at or after 16 years of age do receive a dose when you see them. So this is a vaccine that you're going to focus in for adolescents in your younger population. But you do see many patients who maybe have a spleen that doesn't work well. They actually need 2 doses of this vaccine to get started, and you need to separate them by 8 weeks. And then they get a dose every 5 years. This gets complicated when you look at these age groups, so I've referred you to a website page that will help you in making a decision what to give. Just real briefly, a new vaccine has come on the market, and this is really going to affect very few people. It's called Pneumococcal group B vaccine. They're for 10 and older. You'll see the risk groups listed on the slide, very few people in a risk group. But we're also going to look at our adolescents, again, vulnerable to these particular diseases. And so we will look at vaccinating anyone 15 through 23 with this new vaccine and persons 16 through 18 is the age we're going to start the vaccine. So let's turn to just a few other points, and then I'm going to wrap up so I can take a few of your questions. My email address is on the front. You can certainly get it from MPRO, and I'll answer questions that I don't get to at any time that you send them to me. But I do want to look at a few other points before we conclude. You need to know that it's safe when you give vaccines, so you should look at using a standardized form in order to ensure you're asking the right questions so that you're teasing out any contraindications or precautions for that person before you vaccinate them. This is an example of a national form that's recommended by CDC. So this is one I also will recommend. You need to know that before you turn somebody away from being vaccinated, that they really do have a true precaution or contraindication, not something that you thought was true. So look at these types of screening questionnaires. If you print it out on the back, it tells you why you ask all these questions, and it really will give you benefit in making sure you're ready to vaccinate everyone who can be vaccinated in your practice. The next 2 slides, I'm giving you 2 examples of charts that are available that spell out by vaccine the true contraindications to giving that vaccine to certain people and the precautions that we have in giving that vaccine. If it's a contraindication, no one should receive that vaccine. If it's a precaution, you have to make a decision. Its benefit is higher than the risk of using this vaccine for that person. So these are why they're spelled out in 2 separate categories. And this really will take the physician input to make this clear and final decision. This one is attached to the adult schedule and printed out with it. And so that's a CDC copy. If you go to the immunized.org, the Immunization Action Coalition site that's listed at the bottom, they have 2 forms. They have one that's overall on vaccine contraindications and precautions for children and adults, and one that's just based for adults. So pick the appropriate one for your practice, get this out, keep it close, and when people come in with any kind of unusual thing, antibiotics they're on, anything that you're uncertain whether you can give a vaccine today, refer to these charts and make sure you know it's safe to give the vaccine. The reason I don't cover all these with each vaccine is, 1, there aren't that many here, but it's also hard to remember. And because safety is so important, this is the time where you have to use a chart, not just your memory, to ensure things are done right. Everyone entering your practice who receives a vaccine that's on this routine schedule needs to be handed a copy of a vaccine information statement. Make sure you get these off to our website, our state website, because the Michigan version ensures that you've got their permission to put that data we're asking you to put into the registry into the MICR. So make sure you're using the ones from our website to ensure you've got permission, and then please go ahead and get that data into the registry. Just going to talk just briefly about administering vaccines, one of the last steps in the standards. I'm going to challenge you with some questions. Do you have proper storage units in your office, and do you have the right thermometers to well check those temps? There's a guide I asked you to go to, the MDHHS Guide on Vaccine Management. Go to this, pull it out, and make sure that you do have the right equipment. Bad equipment or wrong equipment, such as North-style refrigerators, can cause your patients to not get the vaccine immunity that you're expecting. Do you stock all vaccines? Do you stock or recommend all vaccines? We'd like to hope that you have all vaccines that are recommended in your fridge. If you don't, though, the standard says you need to refer that person to another provider, not just go get the vaccine somewhere else. Where can they go to get that vaccine? Make sure you use the proper needling, and make sure all of your staff know how to correctly give a vaccine. One of the key components, and particularly in adult vaccines that's come up recently, is shoulder injury related to vaccine administration. Persons that are getting their vaccines way too high in the shoulder, causing injury and sometimes surgical intervention to correct the problem. Make sure everyone knows what they're doing before they vaccinate. And the last part of these standards I want to discuss is documentation. Document all your vaccines administered into the registry. The standard of practice states that all vaccines should go into an information system, and that's what MICR is. If you're doing paper chart copies or EMR copies, make sure that you're documenting everything that's federally required, and those steps are listed on this slide. This is a list of the immunization resources that I mentioned throughout this presentation, so they're in one list for you. And I just want to conclude with saying, remember, we really are counting on you. Your patients are counting on you. We in public health are counting on you to ensure all your patients are protected against these diseases. We appreciate and applaud the work you do, and we hope that you go further and further expand protecting what I consider the vulnerable population for immunizations, and that is our adults. Thank you.
Okay. Well, thank you, Ms. Wolicki, for your insightful presentation. I think we have a few minutes to open the lines for questions. Just as a reminder, we are offering CEs for this presentation for today. Just a couple of steps. First, you will, to access your CE certificate, you'll have to follow the instructions below on this screen. First and foremost, you'll email Samantha, and her email is up on the slide, with the following information for the AMA attendance record form. First, that'll include name, address, phone, and your AAMA member ID. And then for non-AMMA members, you'll want to include your name, address, phone, and the last four digits of your Social Security number. And then additionally, your CE coordinator will submit your information to AAMA, and your credits will be applied to your transcript. So, operator, if we can open the lines for any questions that we might have.
Yes, ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. And our first question is going to come from Robin from Lakeshore Medical Center. Please go ahead.
I didn't have any questions.
Okay, sorry about that. Our next question is going to come from Stacy.
Yeah, hi. I don't see the email address for, was it Stephanie we're supposed to email? Instead it's on the slide, I don't see it.
Oh, yeah, it's actually right in the middle of the slide. It says under thank you for attending, number 1, email Samantha at SS.
I only see remember we are counting on you.
I did fill up.
Okay. It's actually in the chat as well.
In the chat.
That should be the last one there. I can give you the email as well. It is SSTRASS, C as in boy, at mpro, M as in Mary, PRO.org. And Barbara, could you actually advance the slide on there?
I'm sorry. That was my fault. I'm sorry. I apologize to the audience.
And there are no further questions in queue at this time.
Okay. I'll just give it a second here, and then we'll end the presentation. I guess no other questions. I want to thank you again, Ms. Wolicki, for your time and expertise on this subject. And for anyone who would like additional information on our programs through the Lake Superior Quality Innovation Network, you could visit us at www.lsqin.org. Thank you again for attending our presentation.